But before we go to today's NSP, let's look back then, or over the past 5 years. Is there anything that we've been able to achieve that you can say to us that proudly, as South Africa, in implementing the National Strategic Plan, we are now able to say this is how far we've gone in the fight against HIV and AIDS, Dr. Reeds?
I think certainly we can, and I think we really do need to acknowledge the difference that committed political leadership has made to this struggle against HIV. With the Deputy President and with the new Health Minister, we've seen a dramatic change in commitment, and that has really translated itself into programs. I think the very significant things in terms of headline news that we've seen in terms of success are the numbers of people that we've now got onto treatment in the country, which are very significant numbers. We think there are about 5.6 million people who are living with HIV, but we've got now well over 1 million people and climbing on antiretroviral treatment. And those numbers have gone up dramatically in the public sector as well as always in the private sector as well. The two other very big successful interventions have been the prevention of mother-to-child transmission. When we started looking at this, the risk of transmission of an infected woman to her baby was about 30%. With the introduction of more and more and better antiretroviral interventions and other interventions, we've now, at the latest figures, reduced that to just over 3%, about 3.5%. That's a dramatic reduction that we've seen in a relatively short period of time. And the third thing, which I think the Health Minister has really promoted personally, is a very large increase in counselling and testing. So we're really looking at instead of the sort of couple of million a year, we're now looking at 10, 12, 13 million people who've tested. And in the last, I think, 18 months, we've identified over 2 million people from that testing campaign who are positive, who now can get onto treatment, and other people now know their status and can remain negative. So I would say very big progress, but a lot more to do.
Again, because I'm going to go back to the key issue here, and that is the number of people that are being infected on a daily basis. Stats, again, indicate that we have about 1,000 people that are being infected every single day in South Africa, and in that front we haven't made any headway, have we?
I think that's the challenge that we're really needing to look at. I think as a sort of back-of-the-envelope calculation, we think that probably for every person that we're putting onto antiretrovirals in South Africa at the moment, we've still got 2 new people who are being infected. Now that's it's a public health disaster. It's an individual massive problem for the individual patient, but it's unsustainable. We can't go on like this because the costs of running these programs are very, very significant and are taking up a very large amount of the national health budget. So what we really want to do from all perspectives is to focus in the next 4 years of the National Strategic Plan on prevention and to look at different modalities of prevention that will really start to make a difference.
Again, I think what people are saying is that what we are getting wrong, whilst all the political will is there now, and of course also we are getting this treatment going and so on, we are unable to get through to individuals. We are unable to get people at an individual level to make a decision not to be infected.
You're absolutely right, but I think we've also got to understand now that if you're a young person living in South Africa, we've recently published a paper where we looked at the behavior of young people in South Africa and we compared it to data from the United States. And for every parameter of sexual health risk, young people in South Africa are less risky than a young person living in the United States in terms of safe sex and other things that they do. The problem is, if you're a young person here and you even take one risk, the chances of you taking that risk with someone who's HIV infected is very significant. So the drivers of the epidemic in South Africa isn't just behavior. That's certainly something we really need to keep going. It's also about the virus we've got. It's about our populations. there's something biological combined with behavior, and we have to tackle both of those things to really intervene in terms of prevention.
All right, and I'm going to ask people to call us particularly on that. Why are we unable then to get through to individuals on these matters on 0891104208? But let me bring in my other guest here, Dr. Sozi. I was looking at the message that came through from the UNAIDS headquarters, Michelle Sidibe, saying that never before in the history of AIDS have we reached a moment where we are able to stand up and say with conviction the end of AIDS is in sight. It sounds like he's declaring victory here, does he not, Dr. Sozi?
I don't think he's declaring victory. I think what he's saying is trying to keep the optimism. I think more than ever, I think what we're trying to acknowledge is that even in this period of very difficult financial crises, significant results have been made by countries. More than ever, we're seeing more countries stabilizing the epidemic, reducing significantly the number of new infections. We've seen more people being put on treatment and providing care and support. Up to date, globally, there's nearly 6.6 million, and this has had a dramatic impact on saving lives. We're seeing more of a social movement. People are coming together, and we've also seen at the high-level meeting world leaders coming together. So it's not just UNAIDS vision, but people coming together saying it's time to start thinking about the end of the epidemic. And so UNAIDS is pushing the 3 goals about 0 new infections, 0 discrimination, 0 HIV-related deaths, and saying that even with the resource crisis, things can be possible. So let's not just think it's a dream. It can be a reality if we really come together on this.
But some may say in the case of South Africa, to start thinking about the end of the epidemic is premature.
I don't think so. As Professor Rees has said, actually, that with the new political administration and the real headway that's gone with the huge number of resources that have been poured in from Treasury, actually significant results have been made even within that short time. So just think about what would have happened if we had done this investment from a long time ago. I think that what is the main thing that we really need to do is to make sure that those resources are invested smartly and invested in those programs that you really know will produce your results and have greater impact very quickly. Things like voluntary male medical circumcision, really putting our resources, and I know that is in the new National Strategic Plan, the plan of having nearly 4.3 million men circumcised by end of 2016. Putting the money around the elimination of mother-to-child transmission and keeping mothers alive and well. That is another low-hanging fruit, something that's good, produce results very quickly. But if you put more resources into that, that again could, and then really
is that it? Sorry to interrupt you, because is that the issue? Is it the issue of resources? I mean, in South Africa, a lot of resources are going to the fight against HIV and AIDS. But again, in terms of turning the tide, in terms of making sure that people don't get infected, we don't see, and I don't want to sound negative about this, but we don't see the output, the throughput that we need.
Not yet. But note that South Africa has got the biggest epidemic in the world. You've got 5.6 million people living with HIV. You've got like Professor Rees, you've got more, for every person you're putting on treatment, you've got 2 new infections coming up. So it's I think that the big resources, and I think government is putting in about $1 billion every year, which is a huge amount of resources, is covering every program that you can think of. And what we're saying is that focus, go for, cut out the small little programs that are not showing impact and put your money where the biggest results will show. And I think that we've, as UNAIDS, are calling for 6 kind of programs that would make a big difference in this country to move it even further. So certainly, yes, big monies. But, even with the big money, only 37% of the people who are supposed to be on treatment are on treatment. So there's still a hell of a lot more work that needs to be done, and that requires resources.
Dr. Zuma, let me bring you in here, because again, I'm going to say to you, as the UN in New York sounds quite happy, boisterous perhaps, about the progress that's been done. I mean, lots coming through. In fact, even the Secretary General was saying in his message that heading into the 4th decade of AIDS, we are finally in a position to end the epidemic. As South Africans, I get the sense that we're feeling outside of this message, that we're not part of this message where everyone is so positive and feeling boisterous that they are in a position to end the epidemic.
I think I will want to get closer to you there, Kolan, because when we look at our results, our statistics, our epidemic is very heterogeneous in the sense that when you look at the national statistics, we get to hide a lot, because what we see is that the epidemic is stable, which I agree. But because it's so heterogeneous, we need to look at the pockets as to what is going on in different areas. For example, at this time when more people are having access to antiretrovirals, what we expect and what we're likely to see, because the antiretrovirals impact is that people live longer and longer, and in the age group, among people who are in the age group where they are most likely to be receiving antiretrovirals, we're likely to see a slight increase in the HIV prevalence, and that would be due to ARVs. But if we look among young people, among the 15 to 24-year-olds, for example, where the HIV prevalence indicator there is also an indicator, one of the MDG indicators, which also indicates the recency of the HIV infection. Actually, we are not seeing a good picture. I personally don't see a good picture, because what I see there is a slight increase in HIV prevalence. And this is among young people who are 15 to 24 years of age, for example. And looking, for example, at just the recent statistics that were presented among pregnant women, you can see that young kids are actually are getting really more likely to be infected, which is a worrying factor. Now, if you look at the achievements that we have achieved in terms of the PMTCT, which we can see clearly that there is a decline there. Those who are younger than, for example, the younger than 10 years, for example, the prevalence is going down. But then we have a problem whereby this group of the teenagers, for example, are picking up the HIV infection. So when we put this together and average out, we are in a stable situation. But actually, when you look at the pockets, we have a problem.
Now, that's very important, Professor Rees, to break it down and look at who is being infected and therefore ask the question why.
Yes, absolutely. And the reason that's important, obviously, is that you can then focus your prevention efforts in different target groups. So as Dr. Zime has said, the young women remain one of our biggest target populations. We can see from the antenatal data that by the time young women are into their 30s, in pregnant women we've got up to a 37% overall prevalence in pregnant women. That means that still 1 in 3 of our pregnant women are infected. So young women are still vulnerable, 15 to 24 years old, a massive vulnerability there. There are other groups that we also are beginning to focus on that haven't previously been our attention, and we call these key populations. So in the next National Strategic Plan, we're going to be paying much more attention to groups such as sex workers, men who have sex with men, gay men, and other vulnerable groups such as migrant populations, truck drivers, people who are moving. So we're going to be really looking hard at those key populations. But in terms of trying to understand, I think that the other thing we'd still have to just accept is that HIV is still driven by poverty. People who have lower who are living in informal settlements, people who have less access to formal education, girls who are dropping out of schools, all will be much more vulnerable to HIV infections. So side by side with biomedical interventions, with behavioral interventions, with mass media, we also need to look at poverty alleviation and job creation and all of those things that will change the status of people's livelihoods in the country.